Well, hello there, everybody, and welcome to another episode of Rowing Chat. I'd just like to start by asking you, our loyal listeners, to tell us a little bit more about yourselves. We're doing a listener survey, and could you help us by filling out our questions? It's not going to take you long. It's about 5 minutes max. The website address for the survey is bit.ly/rowing chat survey. And remember, the more we know, the better we can make Rowing Chat. Now, today, I'm joined by Andy Franklyn-Miller. Andy, welcome to Rowing Chat.
Thank you for having me.
Now, Andy, could you kick off by introducing yourself to everybody?
Absolutely. Look, I'm a doctor. I qualified at Imperial College in London and then spent 16 years with the Royal Navy. So traveled a bit around the world and then did the bulk of my specialist training in sport and exercise medicine in Melbourne in Australia. And during that period, I was fortunate enough between Athens and Beijing to look after the men's rowing team as team doctor. But prior to that, I was a rowing coach. And so unusually, I really became a doctor in order to make my crews go faster rather than necessarily heal the world.
And of course, rowing and sport injuries are now a well-established niche in the medical profession. What actually happens when an athlete gets injured?
Well, that's a great question, because really we have to remember that the athlete is the one that has the injury. But often, depending on the level, there's both at the younger end, the school, the parent, and the coach involved. And it's very easy to ignore that the athlete really is the one that is suffering. But usually what happens, particularly in an endurance sport like rowing or swimming or many others, is usually there's a mismatch between the amount of work that the body can cope with and what really you're asking it to do. And it's that mismatch where a weakness or a deficit appears.
So whatever training you're doing, and thinking back to my own experience, when I first learned to row, we were taught, for example, weightlifting, and I'd never been in a weightlifting gym before. And sure enough, I got my first injury. So the training that you're putting people under is definitely a contributing factor to what causes an injury.
Absolutely. And no more so than when rowers decide that with a new coach they might run or take up a new weight training program. It's really the adaptation phase. There's really nothing that we can't expose the body to, but it's those huge jumps in load. A patient of mine 3 weeks ago, a 78-year-old lady, actually powerlifts in Europe, having only 2 years ago never picked up a weight in her life. Now, clearly the level's very different from someone in the men's heavyweight 8. But really you can take up anything, provided that A, you're well coached, and B, you understand the goals and the various step-by-step approaches to build that residual capacity or to build that spare effort that you can eat into when you're in the last 500 down at Henley, that you really need to use that. But if you're using it every day, there's always going to be a mismatch.
So talk us through some of the mechanics of injury.
Absolutely. Well, look, in rowing, the one thing that we're well aware is that we're not fully weight bearing. And so the body's designed very well as a series of hinges. And people often talk about, how we can dissipate force or lose load. But in reality, we weigh however much we weigh. So when we hit the ground, when we're running or weightlifting or jumping, we have to distribute that load evenly across the joints. Now, in rowing, of course, we actually perform a pretty tricky mechanism. And so we don't have that luxury of being able to act like a spring. So really in rowing, that's the need for the specificity behind the training behind it, so that we can learn to really build residual capacity and to watch that weakest link. We know very commonly that patients or rowers get back pain, and they get back pain very early on in that rowing career. And parents, certainly in junior athletes, get very worried that it's the weightlifting program that's giving you that. But as we've just described, it's the mismatch between the two. So if you've been training, you're on the water a lot, and you added in weight training, it may not be the weight training itself, but might just be that 24K piece on a Sunday afternoon to get in that UT2 work.
So give us a bit more detail about the different sorts of things that we can do to respond when these injuries happen.
Absolutely.
I'd like to frame it up for a coach or an athlete to recognize the signals and then to know what they should do.
Well, we know that in order to train, we need to overreach. So if we all trained at 60% of our capacity day in, day out, we'd not get faster, we wouldn't get stronger. So in order to get stronger, we need to overreach. We need to lift to the level of our tolerance and a little beyond. And really, it's, there are a number of tools that coaches at all levels can use to really see how that athlete is responding. Now, pain is almost too late. I mean, if we have an athlete with pain, it's likely that they've already overstepped, either with that overreaching turning to overload, or really, as more commonly happens, that we don't allow enough time for recovery. And it's an important part of that training. One of the interesting tools that's available to anybody at no cost, using the camera on a phone, are tools of measuring heart rate variability. And so typically we might wake up and measure our pulse. And if you're fortunate enough, that might be down in the low 50s or even below. If you're less well trained, you might be a little bit higher. And so, but we measure that across, maybe a minute. But in reality, the heart is varying from maybe 20 to 36 to 75 to 99 between beats. And that beat-to-beat variation is a fantastic tool at measuring reactivity. So if we train very hard, we expect the variability of that heart rate variability, or HRV, to narrow. And so you can measure that heart rate variability using a variety of apps for your phone, where you place your finger over the camera and record that each morning. Much more sensitive than measuring heart rate itself, and without the need at the Olympic level of taking morning cortisol and morning urea bloods on a training camp. And so it's a nice balance. And really, from a coach's point of view, a sort of a slightly more, expensive method is that they can monitor those for all of those athletes from afar. So they can log into a website and you can share that data. But you as an individual can monitor that yourself. And the applications, HRV for training, let's say, or Elite HRV, two alternatives, both free, give you a readout of how you're responding.
So first thing is track regularly and know what's normal for you. And so what are you looking for? You've mentioned a morning heart rate measure.
Yep.
What are you looking for in those readings?
What we're looking for is repeated narrowing of that measure. So if you or I had a heart rate which was staying around 64, 65, 64, 63 on a day-to-day basis, we're not allowing ourselves enough scope to recover. Whereas a relaxed body, one that's got plenty of nutrition, hydration, sleep, balanced training load, will have very wide variability. Broadly speaking, that's the sympathetic nervous system, the fight or flight response, where you have the narrowing of that heart rate variability versus the parasympathetic, the relaxed state overnight. So what we're looking for with those measures is really a guide as to how you're responding. If you overreach, it will narrow, but not narrow to a very fine point. If you overtrain or overload, you lose that variability. So it's a good early warning sign before you tip over the edge into fatigue and poor sleep and start wondering why those things might be happening.
That's fascinating. And do you do this on yourself as a matter of course as well?
It's frightening. So absolutely. And you know, the advice I give a lot of my patients when they're starting off this in terms of monitoring, or whether they're recovering from a chronic state, you know, where they've become intolerant, we call it unexplained underperformance. People used to call it overtraining, but it's too simple. But when I start a patient off doing that self-monitoring for 2 weeks, I say to them, look, we're going to ignore it for 2 weeks because really we need to get a baseline. And then as we're building back that training program from the very lowest of lowest levels, we would often allow the software to be ignored for a couple of days, just so that we can sort of step it back at a much more measured approach. But, you know, 15 years ago, this was not available. You know, outside of the Olympic Medical Institute, you really wouldn't have this technology. And so it's available across the board, it's free, and it's just one of those fantastic things that, look, I think, you know, technology has allowed us to advance with.
It certainly is absolutely brilliant. And of course, the one bit that you haven't actually mentioned is first take your measurements and then share them with your coach. Or are you expected to be informed enough as an athlete to watch it yourself and tell the coach if things are changing?
Do you know, it's a very good question. And coaches the world over are no different. I was fortunate enough to work for 2 years as performance director in Melbourne Storm, so a rugby league side. And one of the main barriers, I guess, to this technology was the feeling that the athlete could self-report. So they could pitch up in the morning and say, hey, coach, the application on my heart rate tells me not to train. So clearly, these measures are one and one alone. The beauty about HRV for training, Elite HRV, is that you can share that data with your coach, and there are algorithms available to look for those early warning signs. So it's never the one-off reading. It's really the trend over 4 or 5 days. So it's no excuse, sadly, for missing out that session that you really don't want.
So let's moving on to athlete mentoring. How can you guide your athletes? Imagine we're mostly talking to people here who are rowing at club or masters veteran level and university level.
Yeah, absolutely. And look, and you know, I think the thing here is when we talk about what causes an injury and what causes something to break down and that mismatch of load, the one common denominator there is strength. So we know in order to create that maximal torque, to get the blade out of the catch past the pin, to try to create that maximum leverage, we need strength. And it's an unavoidable fact. We can only gear the boat a certain amount, and we need to be able to produce that power. And so one of the things that really, I guess, is vital in developing that athlete is the ability to begin those compound lifts. So it's the ability to, even if it's body weight when you're an 11 or 12-year-old starting, the ability to get those movements, you know, the deadlift, the power clean, movements that really are the underpinning mechanism of creating the power that we produce stroke in, stroke out. And you start to think about the volume across a 20K piece of the repetition of that. And then you can very easily see where that compound loads are. So it's very easy to ignore that in those early years of rowing when you're building that base. And that, you know, if we build the miles and we build the volume of rowing before we've built an adequate strength, it's not surprising that we'll start to develop stress fractures, we'll start to develop some back pain, hip impingement, and shoulder signs that really are, you know, the weakest link. And it's a little bit like, you know, the car with flat tires. Which bit will go first? You know, is it the wheel rim or is it the bearing? And we're looking for those clues. And so I think, you know, from the coaching point of view, most coaches are very well aware now in terms of the impact strength training has, but how we start to look at those, and actually the technical critique of lifting is also important.
Tell me more about that end of the works.
Yeah, and look, and you know, often there's this fear, particularly parents, younger kids, even coming up into, you know, particularly lightweight men, of this fear avoidance about lifting heavy. And you know, there's a difference, and we'll say this in clinic almost on a daily basis, whether you're rehabbing for an injury or trying to prevent an injury happening in the first place. There's a big difference between exercising a joint or a muscle group or a body and training it. And so in order to train that muscle, it must get to fatigue and it must get to close to maximal lifts. And the perception is that that in some way could potentially be dangerous. Well, you can only lift maximally what you can lift. There's a limit to that. And so you'll not be able to lift 100 kilos off the floor if you're a 35-year-old who's never lifted before. Or likewise, you may well be capable of lifting 100 kilos off the floor if you're a 70-kilogram 16-year-old schoolboy. So it's about that gradual change. And for those coaches, I guess, looking for innovative ways of how to bring those methods before lifting weights into the very youngest athletes, there are some great internet resources in terms of where to go. In the UK, there's a group called Locker 27, based in Weybridge, who are fantastic at developing long-term athlete patterns. But in the US, there's a guy whose Twitter handle, I'm sure we'll be able to pop in the show notes, but a guy called Jeremy Frisch, who really has a fantastic internet-based resource of movement exercises which build up children from 6 through to 19 through those very lightweight initial high repetitions, very similar to what they might do on the water, not targeted at rowing, but targeted at any sport. And his real method there is, look, movement is movement. If you need to produce power and you need to ultimately produce power in a power clean or a deadlift or a squat, then these movements are common across all sports. So certainly I would commend his work to anybody. It's free, it's open resource, and has a lovely set of endless exercises, endless gym work to do, really all designed on controlling and producing movement.
That's fantastic. Thank you. And yes, we will definitely put those links into the show notes. We're going to take a short break to hear from one of our supporters. RowingChat exists thanks to you listeners and watchers watching us, but also thanks to commercial organizations who provide us with cash so that we can pay for our hosting and our publicity. Support for today's show comes from Health IQ, a life insurance agency, who has the common sense to realize that athletes are healthier than the average population. They're such clever fellows. You don't actually have to explain why your body is a high quality, amazingly fit asset. These guys know that you're less likely, in fact, apparently 56% less likely to have heart disease if you're physically active. And rowers aren't just active. We know we're super active compared to the gym bunnies. So get special rates for life insurance and show your support for RowingChat by visiting www.healthiq.com/rowing and ask for your free quote. We know you all enjoy Rowing Chat, and so following through with our sponsors helps us earn some money to pay for our costs. Do it now. Just open a browser so you don't forget to get a quote. healthiq.com/rowing. Now back to Andy. Now, I'd like to talk about the sort of scary end of injury, and that's a word, surgery. What are the situations when that is actually needed to rehabilitate an injury? Absolutely. And look, even the most bloodthirsty surgeons really try to avoid operating in most scenarios. And so clearly there are certain injuries and end of the line cases where really surgery is the only option. Usually the first advice here, though, is there's very few injuries that would affect a rower that would immediately need surgery. Often the temptation is to Google the interesting forearm pain or the interesting hip impingement. And the way we all know Google works is people search for the oddities and the strange things. And so you can all find very easily, if you enter hip surgery or back surgery rower, the first 5 or 6 hits are fantastic cases of rehabilitation after surgery and return to world championship success. Well, look, I'll go back to my first point. These things occur through a lack of strength, usually. And so trying to regain that strength with some coordinated, well-delivered rehabilitation after a definite diagnosis has been made is step one. There are some scenarios, though, where really all of the work that you do may well still be limited by pain. And in a younger athlete around the 17 to 19 group,
One of those is something called spondylolysis or spondylolisthesis, small fracture in the lower back. And fracture sounds scary to anybody. You expect, you're worried about being paralyzed or your leg stopping working or permanent injury. Well, look, they're incredibly common, very common in fast bowlers, very common in gymnasts, in NFL players, and also in hockey. But rowing has its fair share. And really, in the developing skeleton, this bone hasn't fully hardened down at the lower back. And often, rehabilitation is the main treatment. But often after 4 or 5 months, if you still have pain getting in and out of a car seat, sitting down at school or getting in and out of a chair, and you still can't get back in the boat, it's a reasonable effort to say, well, look, enough's enough. I've tried all the strength work. I've tried the conservative measures. And in those scenarios, a wire or a screw into that bone helps reinforce it and allows that fibrous healing. As we get older, on the other end, really, I guess, again, we go back to the weakest link. And often after 20, 30 years in the boat, our back and our hamstrings, hips are very strong. But it may be that the shoulder, the thing that we don't use every day, is very prone to overload. And the temptation there is to rush in and try to stabilize or repair rotator cuff injuries in the shoulder that might occur in the gym outside of the boat. But again, recent evidence really suggests that actually PRA isn't the way to go, and actually that we ought to spend more time focusing on that strength of that particular segment. And then finally, I guess, there's an area where most people have heard of someone who's had an operation to their forearm. We all know if we grip the blade a little bit too firmly, rough water or down the tideway, and we're a little worried about losing it, that we can develop a horrible pump in the forearm where the muscle feels as if it's going to explode. And depending on which avenue you take, you could end up with a surgeon who will describe that as compartment syndrome, where the cling film or the fascia around the muscle gets too tight and engorges the muscle with blood. And that an operation to release that forearm compartment can take away the pressure and take away those symptoms. Well, certainly that's true, and those sort of operations can give you an immediate fix, although I would say, though, that something got you there in the first place. And so often a coach can look at that from a technical point of view. And one of my most rewarding, I guess, parts of the job is that when I see a rower with this forearm pain who's been referred for surgery, is to be able to sit down with a coach and look at the video and then demonstrate really the underlying mechanism there, and sort of make some suggestions in terms of drills and exercises that really you can coach it out of this. So it's rare to find yourself in a scenario outside of that small group in the youth, or really towards the other end of the spectrum, where either the spine would need an operation or indeed the hips. And often we find that you end up with an operation mainly because either there's pressure to make the team, there's pressure to gain the funding to make that race in order to get into the A final to hit that target. And so it's often not so much the injury which causes the surgery, but it's the extraneous pressures, be it the coach, the national federations, or just pure time, when often surgery can give you a defined time point or an exit point from an injury, whereas rehabilitation has a much more of a shifting goalpost, and something that we really in the sports medicine world need to work very hard to start to give those defined endpoints to.
That's a really, really interesting point, because of course any athlete always wants to get back into training, and that is probably the biggest frustration, is not knowing when.
Absolutely. And one of the things that really frustrates me is when a patient comes in and they don't have a firm diagnosis, but they've been using rest as treatment. And if I could have a banner on the wall in the gym of our practice, it would be that rest is not treatment. So resting anything alone doesn't fix either the underlying technical faults, doesn't fix the underlying load mismatch, because you'll go straight back to it. And certainly if it's injury and it's past the point of no return, rest is not going to solve that. So the message there is an early diagnosis, no matter how frightening that diagnosis might appear at first look, because that gives you a time point and it gives you that structure around where you are in terms of your recovery, or indeed the steps you need in order to start that recovery. And
my other frustration is that family doctors are not designed to be sports injury specialists. They're wonderful people and experts in their field. And I've seen so many people go, oh yeah, but we went to the doctor and they just said rested.
Look, absolutely. And, they do a fantastic job and work that actually many of us really just couldn't comprehend in those sort of 10-minute consultations, being everything from psychiatry 1 minute to obstetrics the next. So you're absolutely right. You need a specialist, thankfully in the UK, in Australia, Ireland, and parts of the Netherlands. There's a formal structured postgraduate training program, the same as your cardiologist, or your obstetrician or your vascular surgeon in sport and exercise medicine. So, and the skill set of those doctors, myself included, is both understanding the diagnosis, understanding the various possible investigations, but also the various possible treatment outcomes. And the busiest practices see large volumes of patients. So you're likely to have been seen maybe the 10th, 30th or 40th that week with that case. In our own practice in Ireland, we'd see 240 patients a day. And so it's very unusual for you to walk through the door with something that we haven't seen that week, let alone that month. And so really seeking out that expert opinion is really the answer here.
Yeah, and then that, of course, then gives you the point of departure into the next phase, which, of course, is rehabilitation and hopefully getting well again. So talk us through the process of what we should be looking for in rehab.
Absolutely. Well, it goes back to that diagnosis. So once you have a diagnosis, there are usually two sorts of treatment. There are the evidence-based treatments. Most of those relate to either an operation and then rehabilitation after it, or no operation and then rehabilitation. And the rehabilitation is very sport-specific, but it goes through stages. We have at our clinic 6 stages of rehabilitation, but the first one is actually the diagnosis, because too often you have knee pain or hip pain or back pain. That's just not a diagnosis. There's no imaging there. There's no real understanding of what the anatomy is or indeed the training load. And once you've got that diagnosis, really it's about restoring normal joint range of motion and joint strength. We need to get that side of the hip, or that side of the shoulder, or that side of the back to be lifting symmetrically or as symmetrically as we can with the other side. And we need to be able to restore it to doing or taking the load that you need it to be. If you're an occasional rower who goes out on the water once a month, that load is significantly less than someone training twice a day with 4 weight sessions on top. And so understanding the end goal here is always important. And so, if your 1RM max in a deadlift is 200 kilos, and you're currently able to lift 100, you're not going to fit back into that training boat until we can get you at least to 80% of that. And then we have to talk about the next stage, which really is rate of force development. And it's something we don't really think of. And if you humor me for a moment and imagine the dimmer switch on a wall. So if we flick a muscle on and off, the perception is it's like the switch on the wall without the dimmer switch. But we know that's not true. If we have to lift a bag of shopping onto the kitchen bench, it doesn't take all of our muscle. It doesn't take all of our power to create that. But if we drop the box and have to catch it all of a sudden, we need that muscle, that set of muscles, to work all the more fast. So we need to train the ability of the group of muscles to work at the speed at which we ask them to do it in sport. If we're, an inside centre in rugby, we need to work an awful lot quicker in the change of direction element than we do in a rowing boat. But it's very specific. And through that racing season, we need to train that rate of force development differently. And that's very much part of rehabilitation. If you have a high hamstring injury, we have to remember the hamstring doesn't just work through one angle. It has to work through its full range. And so the removal of pain might occur within 10 days or 2 weeks of an injury starting or being recognized. But actually the ability to restore it to that level of strength, the rate of force development, in order to make sure that we're building enough residual capacity in the muscle close to what it was, is very important. And the other thing there to remember is, of course, that we might have an injured hip. So we might be working on our deadlift, on our rack pull, on our glute ham raises to very much focus on the hip. But if we went into that and we were training for 15 hours on the water beforehand, and we've been out of the boat for 4 weeks, we've got this big gap that's developing physiologically that we need to try to restore. So getting on the hand bike, getting in the awful pool with a pull buoy to make sure we try to maintain some of that repeated cardiovascular stimulus. is really important, and it often needs invention, and it's often where the coach is very useful to say, well, look, we're going to have to forego this UT1 work. We can't do the hour at that sort of submaximal level, but look, let's do the interval work, and let's do the interval work in the pool, and then let's have a little look at your heart rate and see to make sure that we don't overload that. Because for many of us, if we got into the pool and did maybe 850s at maximal pace, it's very different from even 6 250s in the boat, because we're just not used to doing it. And so we could be very easily working right at the top of ATP, CP, right at the very end of our energy ranges, and really overcooking it as part of that maintenance. But we can be smart about it, in terms of we can work on that high intensity work that we're able to do using the body parts we can do it, whilst we regain strength in the area where the main focus of that rehabilitation is.
So that's stage 1, stage 2. And what sort of mental support can people give to an athlete who's going through rehab? Because you think you're missing everything, and it's not just physically, you're not meeting your friends, but you're also really concerned and putting anxieties onto yourself.
Absolutely, and I think that really is very, very often overlooked. The perception there is that, will I ever return? And so the usual way to try to approach is to give common timelines. So we all talk about goal setting. We talk about goal setting through the season in terms of, well, look, by Marlow we might be right. We might hold off, the head of the river versus the national schools. So it's very similar. We need to fit tangible goals along the way in terms of that recovery. I'm hoping you're seeing a specialist who's seen 4, 5, 6, 7 of what you have that month. And so he's going to be able to give you time parameters that are accurate, because there's nothing worse than saying, listen, you're going to hit this milestone at week 3 or week 4, and finding by week 9 that you really haven't made any improvement. And I think it's worth saying at that point, it's impossible to say, what makes a good practitioner. But really here, it's the confidence in meeting those guidelines. If you're making progress in rehabilitation, you're getting less pain, you're getting stronger, and you're meeting the guidelines, that time frame that was set out. Now, no one's perfect, and no one can make that sort of estimate with 100% accuracy. But if you're getting stronger and you're not getting better, there's something wrong. If you're 8 weeks down the line, you're not back and you're no stronger, there's something wrong. And so taking that onus of responsibility on oneself to look at those progression milestones, I think, is part and parcel of that, in terms of you own your body. You're the one who's going to make these changes. We don't have an ability to spray paint strength, exercise, focus back on you. It needs to ultimately come with you. And often from a coaching perspective, there's often no reason why a lot of that rehabilitation can't be done in the gym at the same time as the rest of the crew or the rest of the squad. There are a range of adaptations. A patient with anterior knee pain, very common in getting back in the boat at the start of the year, can work through a part range squat or a top end of a deadlift. So you could be working through the same range. Similarly, with back pain, recovering even from surgery, you could be in the same gym next to the same person. And we'd often in our clinic have an Olympic athlete or professional footballer next to a 65-year-old who might be recovering from a hip replacement in 2 racks next to each other, working through very similar looking sets of exercises, but just at different loads. And I think that's key. You need to be around people who are training, because you're training. And rehabilitation is not remedial PT. It's exercise, it's training. It's just a different level and a different focus.
That is so true, and great insight. Now, when we communicated before arranging this, you talked a little bit about things like beetroot juice. Tell me about the things that we can also do in how we fuel our body that might help us with recovering from the stresses of training.
Absolutely. And look, I guess the simple things here, although it really isn't the sexy, the sort of glamorous thing to say, and it's easy to get wrapped up in the latest fad. And beetroot juice really is there as a prompt, because there is some great evidence. University of Exeter have published some really good results to demonstrate that beetroot juice is a supplement in very well-trained athletes at the highest level. But it's a very, very small percentage. So is that going to take someone you know, from nothing to something overnight? Well, of course it's not. You know, is a year of solid training going to do that? Well, yes, it's going to make a much bigger difference. But it's very easy to forget nutrition. And most people don't have access to good, sensible, basic advice, really, in terms of how we fuel. And one of the, I guess, the warning signs for me in endurance athletes who present with that borderline tipping over between unexplained underperformance is a lack of awareness of what they eat. Patients will often say, well, look, I eat loads. I'm starving all the time. I eat well. I have a balanced diet. And it almost feels like they're at school. They're telling you what you want them to hear. And I often would send them away using a free app called MyFitnessPal to record everything that they eat for 2 weeks. And I'm at pains to emphasize, A, they'll hate me for it because it's the most painful thing to have to do to fill in everything that you eat, particularly if you weigh it, you know, if you're cooking it yourself, you have to weigh the ingredients. But the insight is incredibly powerful. And endurance athletes will often refuel very quickly with carbohydrate. So they'll eat something which makes them feel full. Donuts in the worst case. Bagels with a bit of cottage cheese. If they've ever seen a nutritionist, who'll tell them something which is part good but part bad. Carbohydrate, pasta, bread, potatoes, very easy to feel full. And even, you know, a bag of Haribo, it's all sugar. So you get a quick fix. And what happens after that is very quickly your insulin rises and you mop up everything that you have available to you. So your blood sugar rises very quickly. You feel great. The insulin mops everything up, but that's it. There's nothing there for prolonged fuel. And one of the pretty well-researched factors is that really a training athlete who's got a pretty good volume of training needs around 2 grams per kilogram of body weight of protein as part of that recovery. And one of the nice little experiments I often do if I'm giving this talk to a club or a bunch of coaches or athletes is to put up a chicken breast on the screen and say, look, you know, this is a pretty average sized chicken breast. Anybody have an idea of how much protein's in this chicken breast? As you know, it ranges from, 100 grams to 5 grams. And the reality is a sort of, you know, a chicken fillet that we would get in most supermarkets is around the 16 grams of protein mark. So if you're a 70-gram athlete, you need 140 grams of protein a day. That's 5 or 6 chicken breasts. And when you get an idea really of that level of balance, and then you understand how close to negative equity we run in terms of that protein balance, even within a diet which calorifically looks good. You know, I might eat 5,000 calories a day, and we've all seen, you know, particularly the swimmers, you know, who typically run 7,000, 8,000 calories a day. But it's what's in that food. So that division between carbohydrate, protein, and fat, those are macronutrients. Something like MyFitnessPal can do that for you for free. And it's really that insight to have a look at how that works that can be really useful. Would I suggest going out and changing anything wholeheartedly? No, I wouldn't. But actually, you know, adding in 20 grams of protein a day or 40 grams of protein, be it via a whey protein shake or buy 2 chicken breasts, really can make an enormous difference in terms of A, how you're adapting to a strength program, how much stronger you're getting, because those muscles need the amino acids in order to grow. But also, and primarily, because if we're relying on carbohydrate to fuel our sessions, it's mopped up and wasted very quickly after that session. And so we're never really at our best, be it at school or at work, you know, after that session. And so the inability to recover, really, nutrition is one of those huge things that I think people almost believe they do well because they have a bit of granola and yogurt in the morning and have the odd bagel and put it together in that sort of way. But really, it's quite telling.
That's absolutely fascinating. Of course, that the unexpected corollary of an injury is what are you putting in your mouth? And of course, it's obvious, but it takes someone like you to mention it. So I'm sure that all of our listeners are going to be racing away and having a little check. I certainly use MyFitnessPal. It's a really handy app. As you rightly say, it's a discipline, just like training.
Yeah.
Now, any last bits of advice, Andy, before we end the session for our listeners?
Well, look, you know, one of the things that, you know, I wish we could all do is give away free services. You know, it would be lovely to sort of have a reach everywhere and be able to say, well, look, if this happens to you, do this, or if this happens, do that. Well, there is a guy out there who does pretty much that, which is remarkable. And do you know, many of us will have grown up with the advice that we should stretch before training, or we should work out, stretching is a very big part of what we do. And really, it's relatively outdated. We know if we stretch a muscle, we actually cause it some damage, we can elongate it. But if we then ask it to perform your best ever 40 strokes off the start at maximal effort, it's not going to perform well. It's really not going to have an optimal tension. The rigging almost between the body, between the shank, the knee, the thigh, the hip, really isn't going to produce that maximum torque. And so the world sort of moved on towards thinking more about mobility, but mobility outside of training. And there's an American chap who's a physical therapist, so sort of falls between a strength and conditioning coach and a physiotherapist, who has a particular way of going about things, but produces a free resource available on YouTube called Mobility WOD, W-O-D, workout of the day, comes from CrossFit, and really has some, I think, of the best advice regarding hip, back, and shoulder mobility that you can get without paying a fortune for. And it's something that there's no risk involved in that. He talks you through it very well. It's available. It's a resource. You might need to grab a couple of elastic bands or a hockey ball or something to roll around on. But really, in terms of, is there one thing that you can take away that you could do tomorrow that will improve your range of motion, will improve your injury resistance almost, or get you in the optimum way to train, particularly if you're about to go into the weights room, and that works there. And I'd commend it to anybody in terms of that resource without having to spend money on seeing a therapist yourself before that. And clearly most people haven't really the luxury of a full-time training role, and so can't do that.
And that is brilliant advice. And yes, I know exactly who he is. And he's just approached us because he's published a book and wants us to give him some publicity. So I'll put that in the show notes. Yeah. Thank you ever so much for your time, your expertise, your insight, and let's all go out and do our best to fuel well, strengthen appropriately, and hopefully prevent ourselves from becoming injured. Andy Franklyn-Miller, it's been a delight. Thank you.
Thank you very much for having me.